in ICU. One is on HIV infection and then little bit on tuberculosis in ICU I will be covering. So, the objective of this talk would be that we would understand the pathogenesis of HIV and the immune suppressions because of the HIV infection, the impact of antiretroviral therapy to HIV infected patients and on opportunistic infections, the survival benefit of and the chronic comorbidities seen in HIV infected patients, and when to prescribe anti-HIV medications when somebody is being diagnosed to have HIV infections in ICU. I will be also touch upon drug-drug interactions, because I feel that the drug-drug interactions are very important aspect of the critical care medicines, and many of us we are missing the important concerns with drug-drug interactions. So, I will touch upon little bit on drug-drug interactions, then the outcome of critically ill HIV infected patients and the ICU care in a patient with tuberculosis. So, this is just to show you the burden of HIV globally. Like we have almost 3.5 million people with HIV infections, which includes adults as well as the pediatric HIV populations. And if you look at the slides from WHO, the African countries and the India, these are the two the geographic region where the HIV is much concentrated. We should know about how the HIV is being transmitted, because there are several myths about HIV transmission. We should understand that HIV is mainly transmitted by the sexual route. This could be either heterosexual or this could be either homosexual. So, this is predominant mode of HIV transmission. The another important routes which are now less common are the mother to child HIV transmission, the infected syringe and needle leading to the HIV transmission, and the blood and blood products can transmit HIV infection, but we know that the blood safety has improved. The needles and the syringes, they are being used disposable. The only scenario where you may get HIV infection through infected needles and syringe would be the IV drug abusers, where they are sharing the same needle and same syringes and injecting into their venous system, and they are transmitting not only HIV, but the other the blood-borne infections like hepatitis B and hepatitis C. The mother to child HIV transmission is now not a concern, because with the effective anti-HIV medication we can reduce the mother to HIV transmission nearly to less than 1%. So, the important mode of transmission of HIV remains sexual route, which could be heterosexual in India, but the homosexual transmission is a predominant mode of transmission in developed country. Now, this is the basic slide about the pathogenesis of HIV infections and the replications, as well as the target for the anti-HIV medications in a patient with HIV infection. If you look at this cartoon, this HIV with the help of GP120, 160, that binds with the CD4 receptors on the T cells, that is T lymphocyte, with the help of chemokine receptors. So, these are the co-factors which helps the CD4 receptors to bind with GP120, and with this effective binding with GP120, 160 with CD4, the genomic particle of HIV virus will be injected into the cytoplasm, and in the cytoplasm HIV is RNA virus, but it has got the reverse transcriptase enzyme. So, with the help of this RT enzyme or the reverse transcriptase enzymes, this RNA will be transcripts into initially the single strand DNA and then the double strand DNA, and this helix of the DNA will be integrated into the host cell genome. So, the newly formed the double strand DNA will be integrated into the T cell genome and start producing the proteins and the structures related to the HIV infections. And these HIV related proteins are the proteins which will be which requires the protease enzymes to produce the mature HIV infections, and ultimately the virus will be bud out from the cell wall of the T cells, producing damage, destructions of the cell wall, and comes into the blood to produce infections to the other CD4 cells. So, this is how the HIV starts infections to the T cells, produces the replications and damages the T cells to produces immunosuppressions. So, we have the targets, like for the first target is like the when the virus attach with the CD4 cells, we can exploit this by the entry inhibitors and the chemokine receptors inhibitors to produces to not allowing the virus to produces attachment to the CD4 cells. The another target would be the first the replication phase, that is the reverse transcriptase inhibitors. So, we have variety of drugs available to inhibit these RT enzymes or the reverse transcriptase enzymes to inhibit the viral replication. The next target is the integrase inhibitors. So, the DNA which is formed from the HIV related RNA, when it starts integrating into the host cell genome, the integrase enzymes can be exploited by the help of integrase enzyme inhibitors and to not allowing the virus to produces the permanent infections or not allowing the virus to integrate into the host cell's genome. The next target would be the protein, the proteins to become a mature protein, that is the protease inhibitors. We have n number of drugs available in this class which inhibits the protein to form a mature protein. So, these are the various targets by which we can inhibit the viral replication, we can take care of the HIV into the infected persons. Now, before the era of HIV medication, so that is before the era of ART, what happens to a patient? Like when you compare HIV virus with the other viral infection, the other virus is more or less, except hepatitis virus, it produces rapid symptoms. So, once the patient being infected, the persons become symptomatic because of that viral infections and patients can have clinical syndrome. But in HIV infection, there is a prolonged latency. So, once somebody gets HIV infection, there will be a brief viremia, and within 6 to 8 weeks time, this viral replication reaches to a billions copies. It could be a 10 billion copies per ml of the blood. And with this high replication, the person's CD4 are being infected and they are being knocked down dramatically, and there will be a transient and significant decline in the CD4 cells during the early very high replication phase. But during this time, CD4 can cope up with very high replicating virus and can take care of a high replicating virus and starts producing antibodies against this virus. So, during this time when there is a very high viral replication, there is a significant CD4 infections and the drop in the CD4 cells, the person is generally asymptomatic, but with the start of producing antibodies, the persons may get the first illness, that is we called as acute retroviral infection. And here the patient's clinical presentation would be a simple flu-like syndrome. So, patients can have the running nose, some body pain, fever, myalgia, some sore throat. Patients may notice the enlargement of the cervical glands, or patients can have skin rashes, especially over the trunk. Patients can have skin rashes over the limbs. So, I mean, this is a routine common viral-like syndrome where you cannot, I mean, identify, it is common flu-like syndrome. So, and these are the patients who can have the natural recovery from this flu-like syndrome in 5 to 7 days time. Very rarely this acute retroviral syndrome or the acute HIV syndrome can have fulminant course like Candida esophagitis, pneumocystis carini, or the infection that we generally see in full blown HIV infected patients can be seen with acute retroviral syndrome. But by and large, it is a simple flu like syndrome, and many patients may not seek a medical advice for this first illness that he experienced with HIV infection. After this, there will be the significant harmony between the replicating virus into the peripheral blood as well as the CD4 turnover. But by and large, the daily turnover of the HIV virus will be the same. So, it is very high and it could be in the billions copy, and the study says that, I mean, it could be a 10 billion copies of viral replications per day, and the similarly you will also notice the CD4 cell will be also having the same turnover, and this tug of war between CD4 cells and the viral replication may last for 5 to 7 years for HIV-1 infection, and after 5 to 7 years the patients may develop progressive decline in the CD4 cells because of the ongoing uncontrolled HIV replications producing damage to the CD4 cells, and patients can develop the significant syndromes once the 5 to 7 years completed and patient's CD4 count drops below 200. And this is a time where the patient becomes very symptomatic because of the HIV related opportunistic infections. During this 5 to 7 years of asymptomatic phase, patients may not have significant infectious complications except the herpes zoster occurrence, or patients can develop recurrent pneumococcal pneumonia, or patients may remain entirely asymptomatic till patient CD4 count drops to below 200, where the entire syndrome of AIDS starts. So, these are the list of antiretroviral agents. You can see there are nucleoside, nucleotides, non-nucleosides, pharmacokinetic boosters, integrase inhibitors, and the protease inhibitors. So, these are the drugs that we use in combinations to treat HIV infected patients. And in recent additions to these antiretroviral agents are fusion inhibitors and the CCR5 antagonists. Now, how do we diagnose? This is very important, because many times what happens, like the patient is being admitted to the ICU, and as a part of routine screening, like when we send ICU profile, where we are looking at biochemistry, we are looking at the various blood parameters, which also includes hepatitis B and HIV screening also, and the test come positive. So, how do we diagnose, like how to interpret this test that you have ordered in the ICU admitted patients and the test comes positive? So, how do we diagnose? Like for a diagnosis, like there is a recent change in the guideline of diagnosing HIV infection. If you are using a 4th generation ELISA as a screening tool, which contains antibodies against HIV-1 and HIV-2 along with P24 antigen. So, if your hospital is using 4th generation ELISA, then this test is very sensitive and very specific, and the window period with the 4th generation ELISA is cut short to 2 weeks, which is generally 6 to 8 weeks time, because it contains P24 antigen. So, once your P24 antigen based test, that is 4th generation ELISA, comes positive, then you should do a rapid test, which is commonly used as a tri-dot test, or any rapid test can be done, which can differentiate HIV-1 from HIV-2. This step is also very important. So, for diagnosis of HIV, the 4th generation ELISA, if it is positive, then you have to go for a rapid test where you can differentiate HIV-1 from HIV-2. This differentiation is very important, because the treatment protocol and the drug that is effective against HIV-1 are different from HIV-2. So, some of the drug which is effective on HIV-1 are not effective for HIV-2. So, that is the reason that we need to differentiate between HIV-1 and HIV-2. Previously, like we used to go for a Western blot test. Nowadays, like it is not recommended or it is not required for a confirmed diagnosis of HIV. There are molecular tests like PCR based tests, HIV RNA or HIV DNA qualitative assays, and the viral load test that is we called as RT-PCR or the HIV viral load test. You can also take an help of HIV viral load for the prognostications and the initiation of anti-HIV medications. How do we treat? Right, this is a general guideline not applied in ICU. We will discuss when to start ART in ICU, but by and large, all nowadays in 2015, all HIV infected patients, irrespective of their CD4 count, requires anti-HIV medications, because starting therapy early provides a significant benefit not only to the patients, but also in the prevention of HIV transmission from person to person. Right. So, the all current guidelines, all international guidelines, WHO guidelines recommends starting anti-HIV medications to all HIV infected patients irrespective of their CD4 counts. When you look at the history of antiretroviral therapy in early HIV epidemic, where we do not have much medications and only the NRTI drugs were available, using a single drug to treat HIV can give us a transient improvement in the CD4 count, little bit decline in the HIV viral load, but again it shoots up very rapidly and person again becomes symptomatic. When the second nucleoside comes in the market for management of HIV infection, there will be a further decline in the HIV viral load. There is a little sustained improvement in the CD4 cells, but again in less than 48 weeks time the response disappears with to NRTI also, and the virus develops resistance to the drugs that you are using to treat. But in 1996 onwards, so in early 90s, when the third drug, that is protease inhibitors, available, there will be a sustained reductions in the HIV viral load, and which remains undetectable for a longer time, with there is a significant and steady improvement in the CD4 cell count, and all this has translated HIV, which was opportunistic infections or the disease of infections, to a disease of non-infectious chronic comorbid related disease. So, the infectious problem of HIV has been transformed into the non-infectious complications. So, this is another, I mean, the famous study that we published by the Palela in NEJM in 1998. Once the protease inhibitors, I mean, were available in the management of HIV, you can see that once the use of protease inhibitor increase in the management of HIV, there is a dramatic and sharp decline in the death rate related to HIV infection. So, HIV patients, they live a longer with normal and the good quality of life with the help of anti-HIV medications. So, this is what I mean, I just discussed that, I mean, because of the anti-HIV medications, the HIV has been transferred from the life threatening infections to a chronic manageable infective conditions. And in fact, like in these chronic manageable infective conditions, it has become a non-infectious morbidities like lipodystrophy, dyslipidemia, cardiovascular morbidities, premature aging, bone and health related problems, the renal issues, the liver related issues like chronic liver disease because of the co-infection with hepatitis B and hepatitis. So, these are the complications or the conditions that we face because of the effective anti-HIV medications. So, broadly we can divide the entire HIV epidemic into the pre-HAART era, that is early HIV epidemic where we do not have medications to treat HIV patients. Then the early HAART era, that is in the 90s, where we have the first generation nucleoside analogs along with the protease inhibitors available to treat HIV patients. Though we had a good and sustained response in terms of CD4 recruitment as well as the viral suppression, but all these drugs were very toxic and can produce severe life threatening the side effects which can lead the patients to ICU hospitalization. So, we will discuss that early ART era and the drug toxicities and the ICU requirement of HIV infected patients, and the post ART era, that is the current HAART era, where the non-infectious metabolic comorbidities predominates, which leads patients to hospital admissions or the ICU hospitalization. So, in early HIV epidemic, where we do not have an access to any effective combination therapy, the people or the scientists feel that there is no role of ICU in management of HIV infected patients. Reason is that, like, these are the patients who are likely to get recurrent infectious complications, notably the pneumocystis carinii, candida esophagitis, recurrent diarrheal disease, and all these infectious complications leads to the wasting and the severe wasting and severe negative nitrogen balance of the patients, and these are the patients who ultimately succumbs to recurrent the infections related complications. So, the clinicians and the ICU critical care specialists feel that there is no role of ICU care in HIV infected patients, where these are the patients we are likely to get the recurrent infectious complications. So, the healthcare workers were discouraged by high mortality, recurrent infectious problems, and the poor long term outcome of these HIV infected patients. Mainly the ICU admissions were related to the pneumocystis carinii, cryptococcal meningitis, tuberculosis and disseminated TB related issues, toxoplasmosis and cytomegaloviral infections. And the patients, when they are admitted with pneumocystis carinii with respiratory failure requiring ventilatory care, they have very high mortality of 77 to 91%. So, you can imagine that almost 90% of the patient admitted with pneumocystis carinii, they die because of their respiratory failure and respiratory complications. So, in the early HIV epidemic, you know, the diagnosis of pneumocystis carinii, like it is very simple, like whenever HIV infected patients presented to your clinic with progressive increase in the breathlessness, dry cough and fever. So, this is a triad of symptoms where you can suspect that these patients can have pneumocystis carinii over a period of 2 weeks. So, I mean, this gradual onset over a period of 2 weeks, dry cough, progressive worsening of the breathlessness and fever is probably a sufficient clinical clues where you can suspect that patients can have pneumocystis carinii infection. And in advanced PCP, like if you are getting a CT scan done, you will find a bilateral ground glass opacities. Generally, the CD4 count of such patient is less than 200, but it is not uncommon to get pneumocystis carinii when patient CD4 count is between 200 to 350. So, it is not necessarily that less than 200 patients only will develop pneumocystis carini. Patients with less than 350 can develop pneumocystis carini, and the treatment of pneumocystis carini is very easy. You can treat them with co-trimexazole, that is commonly known as Bactrim therapy. The dose of trimethoprim in a Bactrim component is 15 to 20 milligram per kg in divided dosage, right. So, it is very easy, and these are the patients with severe hypoxemia requires ventilatory care, and these are the patients also should receive steroids, corticosteroids, which reduces the alveolitis, improves the gas exchange into the alveoli, and stabilize the oxygenation in the patients. And use of steroid in a pneumocystis carini patient with advanced HIV infection with hypoxia improves the survival. So, it is not that steroids will further diminish the immune system and leads to the poor outcome. In fact, it improves the outcome in patient with pneumocystis carini infection. Duration of therapy is generally 3 weeks, followed by a prolonged chronic suppressive therapy with co-trimexazole, that is Bactrim. The patients may require ICU admission because of the bacterial pneumonia. The pneumococcal pneumonia incidence is very high in HIV infected patients. So, you may get community acquired pneumonia because of pneumococci. Tuberculosis, of course, like pulmonary and the extrapulmonary TB can be there with HIV infected patients. Patients can get CMV disease. I mean, it is very difficult to cover all the infections in great detail in this talk, but I can just give you little bit of all infections. Patients can get cryptococcal lung disease apart from the CNS cryptococcal infections, where you can get multiple nodules, or you can get infiltrates, or you may get rarely cavitatory lesions in the lung filled with cryptococcal disease. Pulmonary nocardiosis and rhodococcus, these are the two notorious infections where patient is very toxic, patient is breathless, patient is having a very high grade fever, cough with productive sputum, and the sputum examination or the bronchoscopy can give you a diagnosis of nocardia and the rhodococcus infections. Whenever you are getting a rhodococcus infection or nocardia, always screen their CNS apart from the general examination looking at the skin infections or the skin abscesses. This is very important because both these infections has a tendency to go into the CNS, even though patients may not have significant symptoms. And these are the very serious life threatening infectious complications in HIV infected patients, bringing HIV patients to ICU. In the early HIV epidemic, the HIV patient with CNS conditions, the most important the diagnosis would be a cryptococcal meningitis. In fact, rather than meningitis, it is better to say cryptococcal meningoencephalitis, because all these patients with cryptococcal disease, they have elements of global cerebral dysfunctions, and that is why rather than cryptococcal meningitis, we generally says that it is cryptococcal meningoencephalitis. Presenting complaint is very simple, like patients can have only headache with HIV infections, and this could be a cryptococcal meningitis. No need to look at the features of raised ICP or features of meningeal irritations like neck rigidity or Kernig signs or Brudzinski sign. Patients may not have anything, the only headache, and this could be a cryptococcal meningitis. Diagnosis can be arrived by the CSF examination or by the checking blood with cryptococcal antigen test, or checking urine for cryptococcal antigen test can give you insight about the cryptococcal infection in your HIV infected patient. But the CSF examination is very important because it will tell you about the inflammations into the CSF, plus you are also growing a fungus into the CSF. So, you can also use CSF culture to guide your anti-cryptococcal therapy, that is antifungal therapy. The fungal brain abscesses are not uncommon. These are the patients who can get CNS fungal disease from the lungs or from the paranasal sinuses. Patients can have nocardia brain abscess, patients can have CMV encephalitis, patients can have progressive multifocal leukoencephalopathy and HIV encephalitis. So, the variety of neurological syndromes can be seen in HIV infected patients, bringing them into the ICU. Yeah, in early HIV epidemic, the HIV patients can present to the ICU with GI symptoms, and this can be because of abdominal tuberculosis, chronic small bowel secretory diarrhea, CMV colitis. AIDS cholangiopathy is also very common when somebody's the CD4 count is less than 100. Patients can have hepatobiliary cryptosporidiosis and the Mycobacterium avium intracellular infections. All these conditions can give you a variety of abdominal syndromes. And most important thing is chronicity, like these are the patients who gets recurrent abdominal symptoms, and They went into the ICU because of the electrolyte imbalance, the dehydration, chronic febrile illness and the malnutrition. So, just to summarize this early HIV epidemic, that is the pre-ART era, the opportunistic infections were the leading cause of ICU admissions. The pneumocystis carini was the leading cause for ventilatory care in HIV infected patients, and the ICU hospitalization in HIV was associated with very high mortality. In early ART era, because of this, the 2 nucleosides plus availability of protease inhibitors, the patients are now getting immunological response and the virologic suppressions, and they are getting a good quality of life along with the survival benefit, but they are associated with significant toxicities, and these toxicities are lactic acidosis, the nevirapine, the non-nucleosides that we use to treat HIV infected patients related hypersensitivity, abacavir related hypersensitivity, and the Stevens-Johnson syndrome with toxic epidermal necrolysis following the use of nevirapine based therapy. So, I will take you to the lactic acidosis. You all know about lactic acidosis that you see in ICU patients because of the hypotension and prolonged shock, that is anaerobic lactic acidosis, but in HIV infected patients the lactic acidosis is because of the mitochondrial dysfunctions, and these are the patients whose blood lactate level is more than 5 millimole per liter. Patient is having the prolonged exposures to the NRTI, and the commonest NRTI which gives you a lactic acidosis are the D drugs. These are the DDC, that is zolcitamine, DDI, that is didenosine, followed by stavudine. So, these are the 3 important drugs which gives you a lactic acidosis in HIV infected patients. The other NRTIs like lamivudine, zidovudine and abacavir can contribute to the lactic acidosis, and most of the time the patients are receiving combinations of these 2 NRTI giving syndromes of lactic acidosis. This is our experience on the lactic acidosis that we have experienced in our HIV infected patients in earlier time. In year 2004 we published this, and look at like all these patients, they are taking this 2 NRTI based therapy and receiving D40, that is stavudine based therapy along with lamivudine, and the risk factors that we observed were obesity and steatohepatitis, which is again toxicities from this NRTI which produces mitochondrial damage leading to steatohepatitis and accumulations of lactate. And basically this lactic acidosis is because of the poor handling of lactate by the diseased liver, right. So, liver cannot handle the generated lactate by the tissue, and it will be accumulated because of this the diseased liver and producing syndromes of lactic acidosis, which is a life threatening conditions, and you need to diagnose this lactic acidosis early and provide appropriate care, supportive care along with removal of the toxic agents. The nevirapine is another important drug which gives you a significant toxicities leading to the ICU hospitalization, and I told you that nevirapine hypersensitivity and Stevens-Johnson syndrome, these are the 2 conditions where patient requires the hospitalization into the ICU. And the risk factors for getting nevirapine related toxicities are female gender and the baseline CD4 count of more than 250 for the female and more than 400 for the male. So, these are the well recognized risk factors for the occurrence of nevirapine related significant toxicities, but there are conflicting results from other studies where they could not correlate these risk factors for occurrence of nevirapine related toxicities. Let me take you to one interesting clinical case that we have handled related to the nevirapine toxicities. She was 35 years female residing into the Rajasthan, came to our clinic in 2011. She was asymptomatic and diagnosed to have HIV infection with CD4 count of 255, and she was started on fixed drug combination therapy which contains tenofovir, emtricitabine and efavirenz. Her husband was also HIV positive, had disseminated tuberculosis, alcoholic liver disease, he had alcoholic pancreatitis also, and he was also on antiretroviral therapy. So, this lady tolerated anti-HIV therapy well, and she has a very good immunological response to the therapy. She skipped 2 visits with us but she continued with antiretroviral therapy, and she had visited antiretroviral therapy centers into the Rajasthan, where her ART was changed from this tenofovir emtricitabine and efavirenz to AZT 3TC nevirapine, that is zidovudine, lamivudine and nevirapine based therapy from April 2012. So, she was stable on tenofovir based therapy and her intraretroviral therapy was changed to zidovudine, lamivudine and nevirapine from April 2012. Remember that her baseline CD4 count was 255. So, she attended ART center after change in her intraretroviral therapy after 2 weeks with fever of 101 degree with body pain and generalized erythematous skin rashes. So, with this complaint she has attended her ART center and she was prescribed some antihistaminics, antimalarial and paracetamol. But she continued to spike high grade fever, attended private practitioners in the Rajasthan and he diagnosed that this is a typhoid fever and jaundice and he prescribed cefixime. And her WBC count was 5400, malarial parasites were not seen, bilirubin was 4.5 total with direct 3.2 and SCPT was 185. So, she visited our clinic after 8 days of this febrile illness that she has attended to the ART center. So, when she came to our clinic, she has very high grade fever with skin rashes, nausea, vomiting and abdominal fullness. Examination showed icterus, she was conscious, the WBC count were normal. There is mild leukocytosis, the rest of the thing is normal. You can see the skin rashes shown in this slide, that these are the diffuse erythematous with raised margin and distributed all over the body including the trunk, limbs and the face. Her SCPT was 4200, SCOT was 3800, bilirubin was 16.9 with 11.7 direct and alkaline phosphatase was 5 times upper level of normal. The creatinine, amylase, lipase, uric acid and electrolytes were normal. So, you can see there is significant acute liver toxicities plus skin involvement in a patient who has received nevirapine based therapy of less than 3 weeks duration. She was hospitalized, started on IV fluids and supportive care, her toxic ART were removed, but 6 hours after hospitalization, look at the dramatic event. She becomes irritable and delirious, intubated, shifted to the ICU. The CT brain showed brain edema, the entire brain was just like a tennis ball. There is complete effacement of the sulci and the sylvian fissure, and there is a fulminant course in ICU with acute kidney injury, ascites, unequal pupil before she dies. So, there is a rapid death after hospitalization. So, whenever the fever is there along with the skin rash, we should be extremely careful because this is a syndrome where you expect fulminant progressions and patients can have, look at this slides. This patient has just simple skin erythema with maculopapular rashes, and if somebody is having fever, there will be rapid progressions and to the moist or the dry desquamation leading to either SJ syndrome or toxic epidermal necrolysis. The use of prophylactic steroids or the prophylactic antihistaminic will not help such patients. There is a rapid progressions, rapid worsening of such patients. So, in early ART era where we have 2 NRTI plus proteasometers, patients were require ICU hospitalization because of the lactic acidosis or the drug related hypersensitivity and the toxicities. The another interesting phenomena that we have seen after putting patients on intraretroviral therapy is immune reconstitution inflammatory syndrome. We also describe this syndrome as a paradoxical worsening or the immune recovery disease. So, but commonly or the popularly it is known as IRIS, immune reconstitution inflammatory syndrome. So, these patients, like when the patient is having advanced HIV infections and started them on anti-HIV medications where patient is harboring either latent infections or the occult infections where the patient's poor immune system has not recognized the active infection and patient has not running any fever or patient is not having any symptoms of underlying infectious problem. And once you put them on anti-HIV medications, there is a rapid recruitment in the CD4 cells, there is a dramatic decline in the HIV viral load. Both these conditions like improvement in the CD4 cells and a rapid drop in the viral load will lead to the paradoxical worsening. So, now this patient previously was asymptomatic, but her occult infections has been identified by the newly recruited immune system, that is recovery in the CD4 cells has now identified the pathogens inside the body and patients presented with the syndrome responsible for that particular infections. So, these patients when somebody has iris into the pulmonary system or into the CNS system, where patients can have tuberculous meningitis or cryptococcal meningitis or aggravations of the inflammations surrounding the neurotoxoplasma lesions, or somebody has disseminated or the miliary tuberculosis or pneumocystis carini, put them on anti-HIV medication, there will be severe inflammations into the pulmonary system leading to worsening hypoxia, severe breathlessness, and requires intubations and the ICU care. So, all these conditions are paradoxically worsening because of the recovery in the immune system, leading to more inflammations and clinical deterioration in the patient's conditions. So, generally these are the patient with advanced HIV infection, CD4 count is less than 100, and this syndrome can occur within days to weeks. So, you can get early the paradoxical worsening, or patients may develop worsening within a week time. And the common iris are, I already told you that either it is a pulmonary or the CNS iris, which can lead to the hospitalization into the ICU. With the current HIV medications, like all these newer antiretroviral therapy are relatively safer compared to the earlier versions. So, first generation nucleosides were very toxic compared to the nucleotides analogs, that is tenofovir, though it is not that safe. Patients can get renal and the bone disease, which can lead to the significant morbidity, but they are little safer compared to the earlier versions of NRTI. So, with the availability of newer, safer and less toxic antiretroviral agents, these patients are living a normal life. So, their life expectancy is in the tune of more than 3.5 decades, and with the recent the antiretroviral therapy, scientists believe that these are the patients who can live into their 7th decade. So, they can achieve the 70 years of the lifespan because of the anti-HIV medications. So, practically we can say that with the availability of anti-HIV medications, these are the patients who lives a normal life, right, just like any other patients. And because of this longevity on anti-HIV medications, the non-AIDS comorbid disease conditions like cardiovascular disease, non-AIDS cancers, COPD, chronic kidney disease, and the cirrhosis, because of the hepatitis B and hepatitis C co-infections are rising. And because of these non-infectious comorbidities, patient requires ICU care and hospitalization for the care of comorbid conditions. The ICU outcome on current anti-HIV medications has improved a lot. So, initially there were conflicting data on the ICU outcome, where the scientists were not happy and the patient's mortality rate compared to non-HIV infected patients was much higher, but nowadays with the current ART, the patients with HIV infections, they have a similar ICU outcome compared to HIV uninfected patients. The only important the conditions where the patients can have poor outcome is CD4 count less than 200, which is a risk factors for the poor outcome in HIV infected patients. Currently, like the very late diagnosis of HIV and leading the patients to the ICU care is a very common scenario, and this is again one condition where the ICU outcome of HIV infected patient is poor. So, these are the data from the San Francisco General Hospital, where they found that the HIV admissions in intensive care in earlier HIV epidemic, that is between 1981 to 85, is predominantly related to the respiratory condition. We have already talked about pneumocystis carini, but when you look at their data from year 2000 to 2003, the miscellaneous conditions, the post-surgical trauma, and the HIV unrelated conditions are increasing cause for HIV patients to enter into the ICU care. So, the summary of post-ART, that is a current ART era and the ICU admission, is that there is a significant decline in HIV related opportunistic infections, except those patients who has been diagnosed very late with HIV and they are first time diagnosed with HIV into the ICU. So, these are the patients where you expect cryptococcal meningitis or pneumocystis carini, neurotoxoplasma. So, late diagnosis of HIV is very important in current ART era. Though the cases of pneumocystis carini has declined significantly, but still we are getting patient with pneumocystis carini even with current ART era. The reason is the poor prescriptions of TMP SMX prophylaxis to prevent occurrence of pneumocystis carini and the late diagnosis with HIV infections. tuberculosis remains a very important opportunistic infection even in era of HIV epidemic, I mean era of the current HIV medications. The reason is very simple, because in India like tuberculosis is endemic. So, even with controlled HIV infections with anti-HIV medications, TB is likely to occur in patient with controlled HIV disease, and that remains a very important infectious complications in HIV infected patients. So, OIs are seen in patient with HIV infections on ART, but the frequency is much less compared to patients not receiving antiretroviral therapy. Now, coming to the question like when we should initiate anti-HIV medications when somebody is hospitalized into the ICU. We have to remember that when you are thinking in terms of starting ART in ICU, two things that you should remember. One is the occurrence of iris that we have described, which can lead to the further worsening in the clinical scenario of the patients, which can kill the patients also. So, iris is one important thing that you should remember before you start anti-HIV medications into the ICU, and second important thing is drug-drug interactions, right. So, drug interactions with all these anti-HIV medications with your ICU medications or with your opportunistic infections treatment medication is very important, and this can lead to significant toxicities, treatment failure of either HIV or with your opportunistic infections medications. So, these two things are very critical when you think in terms of initiating anti-HIV medications in ICU. But when patients requires ICU hospitalization because of either cryptosporidal diarrhea or patient has cytomegalovirus infection or patient has GC virus related progressive multifocal leukoencephalopathy. So, all these conditions or the lymphoma, they respond to your anti-HIV therapy. So, generally we do not expect the iris following cryptosporidal diarrhea, we do not expect significant iris which can lead to clinical deteriorations in multifocal patient with multifocal leukoencephalopathy, except there will be little more weakness, there will be little bit of edema surrounding the PML lesions. Apart from that, patients may not have significant clinical worsening, and all these conditions they respond well to anti-HIV medications. So, their recurrence, their rate of progressions will be well controlled when you put them on anti-HIV medications. So, these are the conditions where you need to put them on anti-HIV medications rather than putting patient with cryptococcal meningitis or patient with active tuberculosis in ICU with anti-HIV medications, where risk of drug-drug interactions as well as risk of iris is much more common in these conditions. So, best thing is that always seek help from infectious disease doctor to think in terms of prescribing anti-HIV medications. So, to summarize this section on the post or the current ART era, that aging related chronic comorbidities is very important in current anti-HIV medications era, where patients are requires hospitalization because of the cardiovascular, cerebrovascular or dyslipidemia related, renal related or the liver related hospitalizations apart from the chronic lung disease and aging related comorbidities. The ICU survival has remarkably increased from the pre-ART era. So, these are the patients who has a similar outcome compared to HIV uninfected patients. ICU clinicians must weigh pros and cons of starting ART initiation, continuation or interruption when somebody is on ART, like when to stop, when to initiate, right. I mean, all these things are very critical decisions and need to seek help from infectious disease doctor, and it should be case by case rather than a blanket recommendation that you have to stop therapy or you have to start therapy. Now, coming to our drug-drug interactions, this is a very important aspect in practicing medicine. You cannot forget drug-drug interactions, and that's the reason that I touch upon this topic in this section. The drug interactions can be at many levels. One is absorption level, distribution level, metabolism level and elimination. I am going to touch upon only the drug-drug interactions at metabolism level. So, there are two sets of system which handles the drugs that we consume to treat any conditions, and one is P glycoprotein and second is the hepatic microsomal enzyme system, that is CYP 450 system. So, what is the function of P glycoprotein? P glycoprotein is a efflux transporter. It actively transport the drug or the compound that is from the out of the cells into the intestinal lumen. So, once the drug is entering into the lumen, like it will be absorbed through the mucosal surface and enters into the cytoplasm, and the P glycoprotein will efflux out the drugs which has entered into the cytoplasm into the luminal surface. And the distribution of this P glycoprotein is into the apical membrane of the intestine, the hepatic epithelial cells, the renal proximal tubules, the endothelial cell lining of the blood-brain barrier. So, these are the sites where you expect the presence of P glycoprotein. So, this is what I have described. So, when the P glycoprotein is normally functioning, it will efflux out, as it is shown in this cartoon, that from the cytoplasm into the gut lumen. But when the drug which can inhibit the P glycoprotein, like ritonavir, which is anti-HIV medication, which is a potent inhibitor of P glycoprotein. So, what will happen when somebody is on the ritonavir based therapy, the P glycoprotein is inhibited. So, there will be more increase in the concentration of that another drug which is a substrate into the cytoplasm. So, the effective concentration of the other drug which is being actively effluxed out from the cells into the lumen will be very high. So, patient will end up into the toxicity because of that particular drugs. So, when you use ritonavir, you have to be very careful with the drugs which is being handled by the P glycoprotein as a substrate. Now, coming to the cytochrome system, the cytochrome P450 system has important many, there are various enzymes. Out of this, like 3A4 system is very important one. And if you look at the 3A4 system, if the pill is consumed as 100% into the stomach, the drug will be entered into the small bowel, and the small bowel also contains CYP3A4 system which metabolize this drug which is consumed as 100%. And it will be absorbed into the portal circulation, and the 70% of the drug will be metabolized by the gut lumen. So, only 30% of the drug which is consumed into the stomach comes into the bowel and enters into the portal circulation. So, 70% will be metabolized into the intestinal lumen, and from this portal circulation, the 30% of the drug which has entered into the liver CYP3A4 system will further metabolize into the 15%. So, only 15% of the effective drug will enter into the general or the systemic circulation. The CYP3A4 system plus P glycoprotein, both these work together. So, drugs which inhibits the P glycoprotein will also inhibit the CYP3A4 system. So, the effect of the concentration will be doubled up. So, when you use ritonavir based therapy, the way the P glycoprotein is being inhibited, the CYP3A4 system is also inhibited. So, the metabolism of the particular drug done at the intestinal lumen into the liver will be inhibited by the same drug. So, the effective drug concentration entering into the systemic circulation will be much higher, and you will end up into the toxicities. So, the common ICU medications which need to be taken care when patient is on anti-HIV medications are midazolam and fentanyl. So, when your patient is on the protease inhibitor based therapy, that is ritonavir based therapy, the drug level of midazolam and fentanyl would be very high. So, general recommendation is that you have to use 50% of the dose of midazolam and 50% dose of fentanyl when your patient is in ICU and patient is on anti-HIV medications. The amiodarone, we know that amiodarone has significant drug-drug interaction with many drugs. So, anti-HIV medications also elevate the level of amiodarone, and in fact, amiodarone is contraindicated when somebody is on anti-HIV medications. Proton pump inhibitors, which is very commonly used in HIV, in ICU patients, like intravenous pantoprazole or intravenous ranitidine is very common prescriptions along with the patient supportive care. And when you use proton pump inhibitors, it inhibits the absorption of atazanavir, that is anti-HIV medications. So, it will lead to the treatment failure of HIV. So, use of proton pump inhibitors is generally not recommended when patient is on atazanavir based anti-HIV medications. Same way rifampicin, we know that rifampicin is a potent stimulator of or the inducers of CYP3A4 system, which leads to the metabolism of many anti-HIV medications and leads to the treatment failure. Voriconazole is a inhibitor of CYP3A4 system, but when you use voriconazole with either nevirapine or efavirenz, it can lead to the variety of drug-drug interactions, and you may require higher dose of voriconazole administration. At the same time, you have to reduce the dose of efavirenz also, even though it is an inducer. So, there is the very difficult drug-drug interactions occurs when you use azole based antifungal therapy along with anti-HIV medications, right. So, only HIV medications which can be used very safely with azole based therapy is integrase inhibitors. So, 2-NRTI plus integrase are very safe to combine with voriconazole or itraconazole in ICU patients. Now, coming to the second part of this talk, that is tuberculosis and ICU. We know that tuberculosis is endemic in India. So, almost all the states are having a very high burden of tuberculosis in India, and TB patients may require hospitalization, especially the ICU care, especially when somebody has disseminated miliary form of tuberculosis. Patients can have significant adrenal insufficiency, and patient entered into the ICU with adrenal failure. So, these are the very common conditions where patient requires ICU care. The things that we should know about tuberculosis in ICU is that whether this patient is contagious, whether this patient is able to transmit tuberculosis to a healthcare worker and to the other patients. So, how do we handle such situation when the TB patients entered into the ICU? So, TB transmission in our ICU or the healthcare facility is very important public health problem, because our ICUs are not that well equipped with the respiratory isolation facilities, and any patient with tuberculosis with sputum positive will be able to transmit tuberculosis to the healthcare worker or to the other patients. And we know that TB is transmitted by the inhalation of droplet nuclei. So, when you intubate this patient, there is a highest risk of transmitting tuberculosis from these patients to healthcare worker and to the surrounding environment, because once you put a tube in, there will be a gush of the respiratory secretions from that narrow tube to your face or the somebody who is doing intubations and to the surrounding environment. Generally, those patients who has AFB positive into the respiratory secretions or into the sputum, or patient has cavitated tuberculosis and patient who has laryngeal tuberculosis. So, these are the common conditions where you expect the high transmissions of tuberculosis into the healthcare setting. So, those patients who are smear positive and smear negative, but the culture positive. So, these are the patients who are at a very commonly associated with TB transmission into your ICUs. So, the other procedures which increases the respiratory droplet and dispersals, like intubation that I already talked about. The bronchoscopy is another procedure which leads to the increased droplet formations and the shedding of mycobacteria into the environment. The inducing sputum by 3% nebulization. So, many times like we had a habit to induce the sputum to get a respiratory sample for a diagnostic workup. So, when you induce a sputum, it will also generate a good amount of aerosols of the droplets which can transmit tuberculosis into your environment. The isolated extrapulmonary tuberculosis, which is either into the lymph node or into the gut or into the CNS, I mean this is non-infectious conditions. So, these are the patients who do not require a respiratory isolation, as this TB is not contagious tuberculosis. The immunocompromised patient with predominantly extrapulmonary tuberculosis with normal X-ray chest, you have to be very careful. Despite no respiratory complaints, normal X-ray chest, these are the patients who can have positive acid-fast bacilli into their sputum examination. Almost 10% of the immunocompromised patient with normal X-ray chest, they have sputum smear AFB positive. So, even though they do not have respiratory features, predominantly extrapulmonary TB, you have to be very careful in immunocompromised host. So, how do we control TB transmission in our ICU setup? The most important thing is that we need to have airborne infection isolation room, that is respiratory isolation room, that is negative pressure isolation, which is probably not possible. But when this airborne infection isolation room is not possible, patient should be placed into the enclosed area and should wear a surgical mask and not N95 mask. Simple surgical mask wearing over the face is very important to a patient, because whenever patient speak or patient coughs, the droplet will be behind the mask, and it will be not shed into the environment. So, wearing a mask to a patient is very important, and it is a simple surgical mask. Teach your patient that they have to use the simple tissue while talking, while sneezing or while coughing. And when healthcare worker enters into the patient's room, when patient has cavitated tuberculosis or smear positive tuberculosis, healthcare worker should wear N95 mask. This can reduces the risk of acquisition of tuberculosis. Now, when we should discontinue isolation of patient with open tuberculosis, right. So, when the alternative diagnosis is explained by the clinical syndrome, once you reach to the another diagnosis, you have a clinical suspicions of tuberculosis because of the cavitatory lesions or the pulmonary lesions along with the appropriate clinical symptoms. But once you have confirmed the appropriate other alternative diagnosis, you can remove the isolation from this patient. Once you demonstrate the 3 negative sputum examinations for acid-fast bacilli, you can also stop or discontinuation of isolation, or the demonstration of 2 negative expert MTB RIF results. So, gene expert negative by 2 different separate sputum examination can also leads to removal or the discontinuation of the isolation. And ruling out infectious TB must include appropriate clinical judgment. So, it is not simply that negative sputum sample or negative gene expert, but you have to have important clinical assessment that will also guide you to remove or the discontinuation of isolation. Though the expert TB test detects 95 to 100% of acid-fast bacilli in the smear positive, but the ability of expert test to detect acid-fast bacilli in smear negative is just 50 to 70%. So, 2 negative expert is reasonably okay, but you may miss patient who are smear negative, but culture positive despite taking a 2 expert assays. And expert for at least 2 weeks of TB treatment before discontinuation. So, once you put them on anti-TB therapy, which contains rifampicin based anti-TB therapy, and patient has completed at least 2 weeks, we expect that more than 90% of the rapidly replicating mycobacterial pool has been taken care of by these 2 weeks of therapy, and then you can remove the isolation in this patient who has received 2 weeks of TB therapy. And maintenance of isolation is recommended throughout the hospitalization when you are treating multi-drug resistance tuberculosis. So, no other rule applies. When your patient is having MDR TB, patient should be kept in isolation throughout the hospitalization phase. So, just to summarize this talk on HIV and tuberculosis in ICU, the HIV patients benefited by the ICU care in current ART era. So, give them appropriate invasive supportive therapy for their critical illness. The critical care doctor should keep HIV related and HIV unrelated conditions for critical illness in HIV infected patients, because the chronic comorbidities related ICU admission is rising in HIV patients on antiretroviral therapy. The CD4 count is very important, which can guide us for the differential diagnosis of various HIV related opportunistic infections. We know that some infection occurs with less than 50, some occurs with less than 100, some occurs with less than 200. There is no difference in management of HIV positive versus HIV negative patients in ICU. All patients should be treated with equal care. The drug interactions are very important in HIV infected patients taking antiretroviral therapy, and good hospital infection control and the respiratory isolation practice is very important to prevent nosocomial TB transmission. So, if all the patients were identical, medicine would be a science, not an art, right. Thank you very much for the listening.